I'm Patrick.
I'm Emma.
And thanks so much for coming along. Now, before we get started, we're on Wiradjuri land tonight, so I'd like to pay my respects to elders past, present and future and acknowledge the traditional custodians of the land. So on into the topic, Cytology Zen Mastery. It's sort of a deliberately obtuse title for it, but in all seriousness, Zen is a practice whereby you get deeply involved in your subject matter, and it's about the personal reflection as well. So the aim of tonight is to present not so much kind of a whole series of photos of cases, and this is what a trichoblastoma looks like, and this is what an abscess looks like, or that sort of thing, but to sort of present you with a process that you can then take away and apply in the clinic. So the first process of Zen mastery for cytology is to set up your shrine. So what that involves is your stain, your microscope, and the equipment that you use, your slides and cover slips and things like that too. So the very first thing is with your stain, make sure you've got fresh, clean diff quick, that your skin scrapes and your tape preps and your ear swabs and your grubby skin cytology goes nowhere near. Have it nice and clean and separate just for all your other cytology, because you want to make sure that if you're seeing bacteria down there, that they're actually related to the slide and not something that's just been swimming around and growing in the gunk. Next up, microscopes, and this bit is going to depend a lot on the type of scope that you've got in your own clinic. They vary widely in quality and how they're set up, but essentially one very simple thing you can do, if you've got something called a condenser on your microscope, it's a little lens down the bottom that flicks up and down. Different microscopes have them in different locations.
The really cheap ones don't, guys. Don't worry.
They've just got automatic ones that sit there. But basically, if you're lucky enough to have a microscope that's got one, putting it in the right position means that you will actually be able to get enough light into your samples and have things focused properly. If your condenser's down or it's at the wrong height, then what you're going to see is everything's kind of refractile and a little bit too fuzzy. So basically, if you're on low power, so 4 times or is your usual low power magnification, condenser goes down. 10 times and above, condenser comes up, focuses the light, makes everything better. Then the next part of that is, and even on the cheap microscopes, some of them have this feature, is the actual condenser height button, or knob, really. And the difference that makes is, if it's in focus, everything's nice and crisp. If it's out of focus, so if you've got it wound too far down, because sometimes it's easy when you're going for the focus knob, you accidentally grab the condenser height knob itself, and you won't necessarily notice a change at the time, so it tends to kind of drift out of focus and make everything a little bit fuzzy over time. But having that in the right spot is going to make a big difference. And then with your slides and cover slips, good quality slides, but the cover slips make the most difference, especially when you're getting up into your 40 times magnification. So if you've got, at 10 and 20 times you can get away without one, but when you're up at 40 times, having a little dry cover slip that you can pop over the top of your slide, you don't need to glue it down or fix it down with oil, but having a dry cover slip that goes over your slide when you're up at 40 times will improve immeasurably the quality of the image that you're seeing.
What I'd say for most of you guys is you're probably going to go to oil next anyway. So a drop of oil, a cover slip, and then you can go to oil with a drop of oil and then the lens. If you're just going to hone around at 40 times, you don't need the oil. But if you're going to go to oil, then you need the oil between the cover slip, because then the refractile index doesn't change between the oil and the 100 times lens, and then the cover slip and then the slide. You need that oil in between every step there. So just a drop of oil on your slide, put a cover slip on it, and then you can go. So many students come back from pracs in in other vet clinics, and they say the 40 times lenses are crap. And I'm like, did they get oil on them? Or did you use a cover slip? And if you put the cover slip in, it really clears it up a lot. The other thing is if your 40 times lens gets oil on it, and even sometimes I do that myself, you can just use Windex to clean it. Windex on a cotton bud, that works really, really well. KFC hand wipe sachets work really well as well. So you can easily clean your 40 times lens, but I found Windex works really well.
Cool, yeah, thank you. So leading into that, the next stage is, we've been talking about having a look around at 40 times, and really this is a reminder to contemplate the forest, not the trees, meaning take in the whole slide, start low power, work up to high. Because typically what people do is crank all the way down to 40 times, and then you're waving at Larry and Barry, and they're lovely, but you're far too close in to what you're meant to be looking at. So,
for the board exams, the scopes that they provided in the US didn't have a 20 times lens, and I actually went to all the trouble of carting my own scope there because I couldn't go from 10 times to 40 times because I'd be too far down in one little area and not have a good look around. So I honestly go from 4 to 10 to 20, and then I go to 40 to have a closer look, and I don't use 100 times unless I'm looking to count platelets or red cell morphology or mycobacteria on red cells. So for cytology, I don't use the 100 times lens. How many people here use the 100 times lens?
Cool, so start off at low power, work your way up to high, and as you're going, the sort of things that you keep in mind, cellularity, preservation and preparation. Basically, is the slide good enough quality to assess? Then what's in the background? These are things that will also tell you about the quality of your preparation, as well as some other hints and clues as to what process might be going on. And then you can go all the way down to 40 times and have a look at the cells and the features. So, starting at low power, you're just scanning around, having a look at, on 10 times usually is good to start with. Having a look at things like what's in the background, the stuff between the cells that's not clear space. Quality, the preservation and preparation, and then specific areas of interest, and you sort of file those away in the back of your mind to come back to later, because it's tempting to zoom all the way in, but just...
So from looking at this little bit here, I know that I would be very interested in there. I can't see any individual cell detail there, so the really thick stuff isn't that useful. Yeah.
And then, so this is, the basics of it are pretty simple. In terms of cellularity, low cellularity or high. Preservation, preserved or well preserved or poorly preserved. And then the preparation can either be thin or thick. So if you've got a thick preparation of poorly preserved cells and generally low cellularity, then chances are your sample's not going to be of diagnostic quality. And the difference is pretty obvious. Low cellularity slides don't have much on them. High cellularity slides can sometimes be a little bit difficult to read. So then the trick is kind of finding the space in those slides that you can actually assess.
My tip from that picture there was, see how it looks mainly bloody, if you can see from all the way back there? If something's really bloody and fluidy when you put the drop onto the slide, make it like a blood smear, because that'll give us a monolayer to look at. So anything fluid, make it like a blood smear.
Now, in terms of preservation, the question is which cells you count. The ones that are intact, so we've got little mesenchymal cell, all elongate, but we've got cytoplasm around it. The same with the lymphocytes. These ones can be kind of tricky because they're all round cells. But then
So you're looking for cells that you can still see cytoplasm on. Don't count naked nuclei. As I tell my students, don't judge naked people. We've all got roles where we don't want them. Once they're naked, they're big, swollen. You cannot tell what they are properly. So don't judge naked people or cells.
So there's a couple just off the side. No cytoplasm, nucleus only, doesn't count as an actual cell. And then we've got these degenerate neutrophils as well. They're just smushed. Because neutrophils like to do that sort of thing when there's inflammation going on. They not only vomit and spit acids and things like that, but they also do this neat thing where they eviscerate themselves to try and trap bacteria. But once they've done that, you can't really count them in a differential count. And then thin or thick, it's pretty obvious. If you can see through it, then it's thin. If you can't, then it's thick. So you go looking either in the thin sections or around the edges, and especially with lymph node preparations, that's kind of the tricky part with that, isn't it?
Yep. Yeah. So sometimes that make it like a blood film preparation doesn't work for really fragile cells, and that's where you can go to splatter prep for, say, lymph node aspirates. I try to send in a couple of different ways to prepare the slides. So make it like a blood film for one, go and just make blobs on the smear for another one, because that kind of treats the cells the least, so they have more chance of being intact. Unfortunately, there's more chance they'll be thick, but usually we can see right around the edges and try to come to some kind of conclusion. The other one is where you put the blob on the slide, put another slide on top, just let gravity work, and then gently separate the slides, and then you've got two. I'd suggest keeping one in your clinic to have a look at and sending the other one away if it's diagnostic, because then you've got something to refer to when you get your report back, so you've got a reference that you can keep in-house to get better and better at.
Then in the background, so all the stuff that's not cells makes up the background, and typically we're talking protein, blood, and then fragments of cells and granules and other bits and pieces like that. So protein will usually either be pink or purple. Blood, it's fairly obvious, and some people refer to it as blood contamination, but you don't necessarily know whether it's actual contamination or whether the site you're sampling is just very vascular. Because if you're taking a sample from a hemangioma or a hemangiosarcoma, they're going to have a lot of blood in them anyway. Then fragment stuff and things, so degenerate neutrophils with their sort of smeared nuclear chromatin, or if we're talking lymph node samples, then the things in the background are now, the new formal name for them is lymphocyte cytoplasmic fragments. So you can put that in your reports for clients, and it sounds very, very impressive.
Because that makes more sense than lymphoglandular bodies, right? Yeah. So just plain language, fragments of lymphocyte cytoplasm.
Then we get onto the actual cells in the preparation, and your basic two decisions are, is what I'm looking at inflammatory or is it neoplastic? And that's often kind of your clinical decision-making point anyway. The cells that you're looking at, you've got three options: epithelial, mesenchymal, or round cells. So lining cells, mesenchymal cells hold stuff together, and then round cells do all the other bits and pieces, inflammatory cells, macrophages, things like that. And they have slightly different features. Epithelial cells like to hold hands. They sit there in rafts, quite closely packed together. So this one is from a basal cell tumour, well differentiated. All the cells are all the same size, but holding together really quite nicely. Then mesenchymal cells are your more stretched out, kind of spindloid, fusiform, if you want to get florid with your language. They're elongate, oval nuclei. They've usually got little tails or wispy parts on the edges.
A lot of them might round up once you've sucked them away from their friends. So a common trick for young players is to think they're round cells. So just keep that in mind a little bit.
Keep looking and see if you can find the ones with the tails. And then round cells, arranged individually, round cytoplasm, round nuclei, things like macrophages or monocytes, lymphocytes, plasma cells, all that kind of stuff.
They like their personal space and have discrete boundaries. They're like me sitting really close to Pat.
Yeah.
He's a lovely bloke, but I don't like people touching me.
So then once you've just had a look through and assessed what the quality of your preparation is, what your background features are, whether or not you can make a diagnostic decision from it, then you can go and wave hello to Larry and Barry and check out all of their features. So size of nuclei, number of nucleoli, the chromatin pattern, the cytoplasm, how much there is, what colour it is, whether or not there's anything in it. So if it's a macrophage, whether or not they've engulfed red blood cells or degenerate neutrophils, or if there's granules in there, in the case of things like mast cell tumour or melanoma. And then we're on to, and this is where we start getting a little bit esoteric. So know thyself is all about knowing what you're comfortable with and what, knowing what your own limitations are, where you need to refer and things like that. So to kick this one off, it's quiz time. Get your phones out. We've got a few cases to play along with. So what we'll do is we'll start off with a low power, moderate, and then high power for each of these cases. Then we'll open up a website. You'll have a site to go to, key in a code, and make your diagnosis. So here's a 10 times. What's the general consensus on what we're looking at here?
If you want to move forward so you can see, that's cool too.
So do we have enough cells? Yeah, generally. What type? Round, yep. A little bit closer. And then finally at 40 times, back to Larry and Barry, just without the name tags. So these are our options: mast cell tumour, melanoma, squamous cell carcinoma, hepatoid gland tumour, and histiocytoma. So, skin mass.
Because that's all you give us.
So, yeah, mast cell tumour. Okay, so
everyone who's recently gone through my classes, you can do better than that, can't you? What are some other words you might want to put with that? What do you as clinicians want to know about a mast cell tumour?
High grade.
Yeah, is it high grade or is it low grade? So what do you guys reckon?
High grade.
What do you think about Barry and Larry? I'm a bit scared of Barry and Larry. Being a really massive cell and a binucleate cell. So I'm a bit worried this tumour might be, at least if not intermediate, then high grade. It's a bit too scary for me. There's recent papers out about cytograding of mast cell tumours, and their granularity was the most important thing, but it doesn't count for degranulated cells. So if there's a lot in the background, they're still highly granular. They've just released it all during the collection method. Sorry.
no, all good. Cool. So, next one. Thoracic fluid from an 8-year-old thoroughbred. And in terms of history, all we got was off colour, temp 39, and what was the other bit?
Transported.
Yeah,
from Tassie.
transported from Tassie. So, no, not Queensland. So, low cellularity, not too much going on there. A little bit closer. Any idea as to what those cells might be? Have a guess. Sorry? Yeah, white blood cells. Which ones in particular? Neutrophils, yeah. But they look a bit weird. So they've lost some definition. Yeah, they're degenerate. And then what else is going on in there? So there's your options. And pretty much unanimous. Yep. So lots of bacteria. What's the thing that differentiates that image from sample contamination, from bacterial overgrowth? Yeah, intracellular bacteria. And that's really what you're looking for if you're thinking that something's septic. Now, I guess as a side question, if you've got that sample and you've made that diagnosis in the clinic, you're going to have to start treatment in the meantime. But what decision-making process do you go through while you're waiting for your culture and sensitivity results? And Kelly, I'll throw to you on that one.
Just sneaking in some antimicrobial stewardship where we can. So I think that's something that is really important with any of your septic fluids. And one of the things that I think when they looked at what Australian vets are doing in 2017, it's sometimes we don't go hard enough with those kind of isolates. So actually, this is a situation where we would always want to go broad spectrum. Does everyone know about the Melbourne University prescribing guides for horses? So if you're ever not sure, feel free to have a look on there. But essentially, it's pretty much your penicillin gentamicin, so a penicillin in combination with an aminoglycoside. So plus minus metronidazole, depending. No, well, actually,
Pengent, Butte, the trifecta.
Steroidals, but I think the important thing to think about with our small animal patients as well, for the mixed animal or small animal practitioners in the room, is that recommendation will be the same for small animals, but we'd be looking at an aminopenicillin like amoxicillin instead. So rather than necessarily going straight to your enrofloxacin, metronidazole, and amoxicillin, you'd probably want to also look at an aminoglycoside with your amoxicillin to start with. Thanks, guys.
Cool. Thank you. So, now case number 3, lymph node aspirate from a 12-year-old poodle. So, generally high cellularity. We'll have a look as we go in closer. I wonder if this is working again. Nope, that's still not working. A little bit closer. Have you got enough detail in that image down the back? A little bit grainy. So then, as we're up closer, and there's our options. So what do you reckon? Lymphoma, metastatic mast cell tumour, amelanotic melanoma, or a reactive node?
I'm frantically trying to do my cell diff for my percentages. Going
So I guess, what kind of information would you want to know to differentiate between those options? Yeah. Yeah. What other features would you be looking for? Yeah, in the lymphocytes. Yep, potentially. Things like nucleoli. Lymphocytes typically hide their nucleoli really well, so if you can see them, then that's usually an indication of badness, but not always. It can depend on whether it's reactive or lymphoma. Yeah. So, general consensus for lymphoma. The trick with this one, and this was actually a case where we ended up looking at it around the scope together and sat firmly on the fence of I don't know whether it's reactive or neoplastic. What we're seeing in some of these, we've got quite a lot of small lymphocytes. Some of these larger ones are a little bit plasma cell looking, which obviously on a projected image you wouldn't be expected to make that sort of diagnosis. But then we've got other cells in the background. We've got a couple of eosinophils. There's neutrophils in there as well. So that's the kind of thing where if you've got a dog, say, with generalized lymphadenomegaly, sample from multiple lymph nodes, because if you go for the easiest ones to get, which are usually the submandibular ones, those process so much antigen, so you'll often see reactive change even if there is lymphoma going on. So that can really muddy your diagnosis.
Or you get salivary gland by mistake. So just from those pictures, my tip on that would be, if you can have the time, set it aside and do even just count 50 cells, because those big guys are really big. They're poking your eyes out. And so they're the ones you notice. But if you actually look closer, there's probably more small guys than big guys there. It's just the big guys you notice easier. So try to do a more objective assessment where you're actually counting how many small cells, how many big cells. If you want to, and you can add in an intermediate size. They're kind of the medium-sized cells, but realistically small versus big. And if there's more than 50% big, then I can generally lean towards lymphoma if it's in multiple lymph nodes and the findings are the same. A reactive node, determining one reactive node, because they've got really big germinal centres that are full of those big dudes. So that can be a really hard thing to come to any conclusions on. Yeah.
Yeah.
We still like sampling popliteal lymph nodes in those cases?
It's one of the lymph nodes I would sample, but it often comes with a lot more fat, and the cells don't stay very well preserved from that node traditionally. I've seen some really good popliteal samples, but I've also seen some really bad popliteal samples. So I'd aim for multiple lymph nodes. It's all under one site. All the diagnostic labs I've worked for, it's one price, because no pathologist wants to make a diagnosis based on only one node when it's a body-wide condition. So don't be afraid of sampling 4 or 5 lymph nodes and sending 8 to 10 slides in. That's what we want you guys to do.
Yep. Cool. We sat on the fence on that one.
I try really hard not to do that, because my husband presented me with a white picket fence when I qualified, and because he says all pathologists just sit on the fence. So I try to be as helpful as possible, but that was actually one where I couldn't be. I'm like, because a normal lymph node contains more than 50% small lymphocytes, if there are more than 50% small lymphocytes, I can't call it anything on cytology. I can rule out other non-lymphoid conditions, but I can't call lymphoma unless large cell lymphoma, unless big cells are predominant. Yeah. Yeah.
Yeah.
Yeah, so what would you do next?
Yeah. Incisional or excisional biopsy? Ideally, yeah. Yep. Get us the whole node so we've got as much tissue architecture as possible. Cool. So case number 4, cat with a nasal discharge, chronic mucoid, 6-year-old domestic short-hair cat. There's our low power. And then I didn't have a good 20 times, so we're skipping all the way into the close-up. And your options are a bacterial rhinitis. Is it a squamous cell carcinoma, aspergillus, or cryptococcus? So there we go. So what are these cells up in the background? Yeah, ex-neutrophils. They've eviscerated themselves. These ones? Blood? Yep. And then, how about these ones? Yeah, organisms. How do you know that they're organisms and not cells? Yep, cellular morphology. So there's a bit of variation in size there. With this one, you might even, this is a really good example. So there's a clear halo around it, which might be some sort of capsule. And, yep. So that's given away. Yeah, this is cryptococcus. So if you had aspergillus, for example, you might see longer branching hyphae, whereas those are all individual organisms. Then, and I think this is the last one. So 2-year-old mixed breed dog, skin lump, just over the shoulder somewhere. So here's our low power view. What type of cell? Round, yep. So then your question is, which round cell? And these can be tricky because round cell tumours, especially if they're not that well differentiated, can look quite similar. Histiocytoma, another one, another one, another one. Good.
Justify your answer.
So someone said, someone down the back, they're common. Yep. So the signalment is part of your clue. Younger dogs most likely get histiocytomas reasonably commonly. What else? Yeah, so clear cytoplasm, distinct cells, well demarcated, and an absence of things like granules. So if this was a degranulated mast cell tumour, then we should be seeing lots of purple staining granules in the background. Yeah, good. Last one. Skin mass from a Labrador, and this image is sort of deliberately a little bit difficult to decipher, but because you've got a lot of what in the background? Yep, a lot of blood. Then what are the cells in between? What do they sort of look like? White blood cells? Yep. So, and they're round, they don't have multi-lobe nuclei, so they're probably going to be not neutrophil, starts with L.
They're not much
Lymphocyte.
bigger. They're not much bigger than red cells. That's the tip-off for these guys.
So your options are lymphoma, an infected follicular cyst, fibroma, or squamous cell carcinoma. Which do you think? Yeah. Signalment was 8-year-old Labrador, skin mass. So why an infected follicular cyst?
It's putting someone on the spot.
Yeah. Mm-hmm.
The cells don't look like epithelial cells like a squamous cell carcinoma, and they look like spindle cells like a fibroma.
Yeah, cool. No, good reasoning. So, yep, the actual cells that we were interested in were mostly small lymphocytes. Yeah, so that sort of makes lymphoma less likely. No mesenchymal cells that we could see, and no, yeah, they were all individual, so not holding together like you would expect a squamous cell carcinoma.
They're all small cell lymphocytes as well, and I would be very wary of diagnosing a small cell lymphoma in a non-geriatric animal. They just occur in old animals.
But this one is actually a red herring, and it's deliberately so. That was the histology. And it kind of speaks to the fact that cytology in some cases can be diagnostic. In other times, it's a bit of a screening test. So why do you reckon this showed up as a bunch of lymphocytes and not as mesenchymal cells that would indicate a soft tissue sarcoma? Yeah, exactly. So we've got these large lymphoid follicles throughout the mass, and your lymphocytes are going to exfoliate much more readily than your mesenchymal cells. So that's just kind of a reminder. Always keep working to improve your cytology and things like that. But ultimately, you don't get tissue architecture. There's certain things that you don't get on cytology. Once you're familiar with the examination process, repeating that over and over again, and comparing what you get with the lab is going to be the best way to learn as you go. And one question that I wanted to just sort of throw out there, because I'm not sure what the answer is whether or not photos taken down the microscope with your phone are actually any good. Anyone do it? Yeah, all the time? Because these are a couple that I prepared earlier, and I'm shit at it. Yeah, I know language. Yeah. They can be really useful, but something that I wanted to kind of put up there is be careful. One of these is a histiocytoma, the other is a mast cell tumour. And telling the two apart just based on your phone photo, really, really difficult.
But watch this space, because I really want to do a study in that. Some places are offering digital photo for you to send phone photos in for a pathologist to make a diagnosis of. There's no peer-reviewed paper out there in the literature, but I'd like to supply the local clinics with a phone attachment, take photos. You have to send in the slide because we need to evaluate them together. Sorry, I'll look at the photos without looking at the slide. I'll send out an interim diagnosis based on the photos, and then we'll look at the slide and correlate them and just see how accurate you can be. I mean, there's already limitations on a cytology slide, and then you start taking photos of tiny bits of that slide. We want to know if it's actually a good diagnostic test or not. So watch this space, because that study's about to kick off, and I'm really interested in the findings. Yeah. And hopefully that's my retirement plan, to move to dinner plane and ski and do photography service.
Because it's the way things are going. You know, phone cameras are such good quality. So, yeah, bridging that gap to make things more accessible. That's why you do pathology and not equine medicine. Then the last part of it, so, you know, work with your temple, get to know your lab, build up a relationship, which is all about, so first of all, there's the information that's coming from you to the lab. History and gross description, please, as much relevant history as you can. So as well as signalment, age, breed, gender. We want to know how long the lesion's been there. Gross description, work on your gross descriptive skills. So distribution, whether or not it's well demarcated or poorly demarcated, colour. Then the next part is, it goes back to what Emma was saying before. All of this is basically a lead up to what you can do in your own clinic. Do as much cytology as possible, interpret it yourself, and then compare what you get with what comes back from the lab. So always keep if you can, sometimes lesions exfoliate poorly and all you can get is that one slide. But stain it, have a look yourself, check for the quality of the preparation so that you're sending off something that you know is going to be diagnostic. Then write up your own report and compare what comes back from the lab.
A couple of things. Our lab, most labs have auto stainers because we're dealing with a lot of slides every day, and the auto stainer stains between where my fingers are. So if your stuff's right at the end, we don't get to see much of it, or we have to go through, our diff quick is like a 20-minute diff quick rather than a 10, 10, 10, 10. So it delays the process a little bit as well. So we don't do that often. So try to put your samples in that kind of middle half of the slide. Yeah, that really helps. And the right scheme stain is a lot better at detecting a few things than diff quick, so it is a better stain. Yep.
So things like mast cell granules, for example, which is why that previous photo I put up of the two phone photos down the scope, which is why it's so hard to differentiate the two. One of those, both of those were diff quick stains, and the mast cell granules just don't show up as well. Now I'm going to attempt to anger the technological gods again by connecting there, because what we've got, I've put together a template. So drop us an email at that address that you saw down there. We've got a cytology template that you can then copy and paste and put into your clinical records. Oh, yay, extra things. So history, and I've set it up in such a way to make it simple. So you've got all your options up there. You can copy, paste, delete what's not relevant. Low, moderate or high cellularity, poor or well preserved, thin or thick preparation, all that stuff to set the scene for how good whether or not your sample is diagnostic in the first place, what's in the background, what cells you've got, their size, shape, what the cytoplasm is like, any special features, granules, mitoses, multinucleated cells, all of that kind of thing. So then hopefully, and then following on from that, what your interpretation is. Because in cytology, we don't make diagnoses, we make interpretations.
Diagnosis just sounds way too final
Yeah.
after sucking some cells out and putting them on a glass slide. Like histopath, you get to see the whole architecture and a lot more. So histopath make diagnosis, cytologists make interpretations.
Then some differential diagnoses, always handy to have just for when you're talking through with the client, and what your diagnostic plan is going to be. So hopefully that's going to be something that'll be representative of a complete clinical record for that cytology sample. Fill in the bits that you need, delete the bits that you don't, copy, paste, and you're all good. And that pretty much...
I've got a couple of little tips, is that all right?
Yeah.
So
I've just created that in Google Drive at the moment, but drop us an email and I'll send it through to you.
So when Pat showed the cover slips, it's really good that he's got the lid on it. They collect a lot of dust and it's going to look like crap if you keep the lid off and they collect all the dust that's sitting around. Try to do that with your slides as well. I get to see a lot of your guys' skin cells. If the police ever need your DNA for a murder investigation, they can totally come to my place. Then the other thing with these dips are, all of them contain methanol, but there's a lot of methanol in the first dip, in the fixative. That evaporates with time. So if you notice your red cells on your blood films are starting to look really refractile, it's because there's not enough alcohol left. Even these screw top containers, it still somehow gets out of there. So you do need to replace that one a little bit more frequently. And something that works really well for me when I was in practice and I knew I loved pathology and I didn't want to be in practice anymore, I used to get really grossed out by what grew in our slides. So I don't even dip those dip slides in the dips anymore. I get a pipette and I put a drop of the stain on the slide and I rock it 10 times. Then I tip it off. Then I get the next one with the next pipette, and that way there's no contamination. And the other thing you can do if it's available to you, but it's a bit more finicky, is you can actually filter through one of those round disc filters that fit on the end of syringes. You can filter your stains as you put them into your pots, and that really reduces the amount of debris as well. So just a couple of little tiny tips there.
Cool. So that pretty much brings us to the end of the evening. Any questions on what we covered tonight? Nope. Excellent. Everyone is a Zen master. Well, so we'll wrap it up there. Thanks so much for coming along tonight. I hope you've got something out of it. And if you've got any suggestions for future events and topics and things like that, please let us know. Apart from that, thanks very much for coming along tonight, and we'll see you at the next one.